Anybody there? Can they hear us?
Hey, good morning, everybody.
Morning.
So which one is you now? Oh, Lord. Sorry. Definitely camera disabled by default.
Good morning, everyone. Thank you and welcome to the beginning of our second CME season for the year. Just to let you know, we will be going on with our regular schedule, second Wednesday and the last Friday of every month. And we have 10 CMEs planned until the end of the year. Thank you and welcome to the beginning of our second CME season for the year. Just to let you know, we will be going on with our regular schedule. Sorry about that. We're having a little technical difficulties, but we're getting sorted out. We will be recording this morning's meeting, so it will be available for viewing on the Sunshine Luna website. And so for those who have missed it, you can let them know they can use it on the Sunshine Luna website and claim the CME at the end. So it gives me great pleasure to introduce my head of department, Dr. Gabrielle Hunt Burrows, who is going to come and introduce our speaker.
Good morning, everyone. It gives me great pleasure to introduce our speaker today. Our speaker today is one of our own, having graduated in 2012 with an MBBS degree from the University of the West Indies with honors in OBGYN and distinction respectively in surgery from the Jamaica campus in conjunction with our School of Clinical Medicine and Research. And then in 2009, having graduated from her neurology residency from the University of Missouri in Columbia, and then having completed her neurocritical care fellowship. She is currently in her neurocritical care fellowship, which she began in 2019 at Cleveland Clinic. She is a neurocritical care fellow, as I said, and she is going to be until 2021 the chief as the in this fellowship. Dr. Medea Hepburn has been leading, having been involved in several publications where she has either led or partnered, where she has been involved in publications related to the neurology world. She certainly is making an impact, and we are pleased. It is an honor. It is a privilege to now welcome her as she speaks to us today. We certainly envisioned that Dr. Hepburn would have been engaged in trying to gain a better understanding now that we are impacted by the coronavirus epidemic. And certainly she has been trying to gain a better understanding of how this disease infects the nervous system. And today she is going to speak to us today about the effects of coronavirus. And so today we welcome Dr. Medea Hepburn. Thank you, Dr. Hepburn. And we listen eagerly. It is an honor and a privilege.
Thank you so much, Dr. Hunt Burrows. I really appreciate that really kind introduction. I was really excited when yourself and Dr. Black reached out to me to have this talk today, and so at the end of the day, neurology is super fun. So I'm really happy to be able to share this this information with you guys. I'm just going to share my screen here. Just give me 1 second. Can everybody see my slides? I hope so. All right. If at any point in time anything I say is unclear, or you want to ask a question, please feel free. This should be, we already are in a virtual format, so please feel free to ask any questions you like. Today we're going to talk about the neurological manifestations of the coronavirus 2019 disease, and I call this uncharted synapses, mainly because there's so much that we just don't know. So I have no disclosures, except the only disclosure is that this is not my office. So those are not my certificates, unfortunately. I'm borrowing an office from one of my attendings here at the Cleveland Clinic. But today we're going to talk about our objectives. So first we'll talk about essentially the timeline of a pandemic, the rise of the human coronaviruses and SARS-CoV-2, neuroinflammation and viral infections, how they interplay with each other, what information we have already. And then, some of the data surrounding the neurotropic effect of the SARS-CoV-2 virus. What do we know already, and what kind of hypothesis are we going for? And then, in short, we're going to talk about the neurological manifestation of SARS-CoV-2 and within the novel coronavirus disease. And a lot of this information is going to be based upon some of the research that we've already done here at the Cleveland Clinic, and as well as kind of information that we as neurologists have all gathered together. And then we'll talk a little bit about what data do we have about long-term neurological implications of the SARS-CoV-2 infection. What do we know so far, and what do we think is on the horizon? In terms of a timeline of a pandemic, December 31st, there were these cases of pneumonia, unknown pneumonia popping up in Wuhan, China. And basically, a little while later, there was identified a new virus as the cause of this disease, named novel coronavirus 19, because it was discovered in 2019. And the etiological agent was, of course, the severe acute respiratory syndrome virus 2. And so by about January 20th, other countries, started reporting cases, throughout Asia, Europe, and of course the United States. January 23rd, we have, Wuhan, which is a city of more than 11 million people, essentially was completely shut down. And by January 30th, the WHO declared a global pandemic. And in April 26, we had, information that the global death toll had already surpassed 200,000. And, this is data taken basically last night. But up until last night, we had over 11 million confirmed cases and over half a million deceased as a result of this, this pandemic. And it's changed the shape of our world. So these are pictures from hospitals in Italy and China, respectively. You can see that, essentially how you came to work as an intensivist or even as a person working in any of these hospitals, completely changed. Not only did the shape of the hospitals change, but the shape of basically the world outside the hospital changed. Here in the United States, we have quite a lot of long-term care facilities, nursing homes, lots of people who are elderly, immunocompromised, and vulnerable. And as a result of the coronavirus 19 disease, essentially everything changed. All of these persons essentially had to be closed off, social isolation, and it was kind of heartbreaking. You have patients with severe dementia, who had been used to a routine, to seeing their family, their loved one, even if they may not know their name, but they were used to that person coming to visit, and now they were no longer there. We had all kinds of, everyone that's aware of pictures of, persons having to communicate through windows and whatnot. Even the way we set up our ICUs changed. This is a neuro ICU in Wake Forest, where they basically had, they now started to put essentially the pumps and the IV pumps and the ventilators outside the room and run the tubing into the room, because in order to decrease the amount of times you're going in and out of the room, and the amount of PPE that you're using. This is a picture actually from the Cleveland Clinic. This gentleman, this is posted with his permission. This is actually one of the first patients in Ohio treated for COVID-19. In our ICUs of the Cleveland Clinic, we basically have like glass, all enclosed in glass. So it's like clear. And so what happened was that the nurses, when they would go inside, or physicians when they go inside, we'd communicate by writing essentially with dry erase markers on the windows. And this gentleman, he actually was, severe ARDS, sedated, paralyzed, was on ECMO. Eventually he did get better. This guy actually got extubated and went to rehab and eventually went home. But as he got better, he wrote this, he wrote this on the window. He said, "This window has been the most impactful window in my life. On days when I watched you work hard to keep me and others alive, unable to thank you." So these patients, he got better, and he was able to basically use this window as the way to communicate with everybody else. Let's talk about in terms of just generally the coronavirus. So the coronaviruses are basically a large family of viruses. They're single-stranded RNA viruses that enveloped, and they really can cause a wide range of illnesses, from mild respiratory tract infection to more severe diseases, such as the Middle Eastern respiratory syndrome and the severe acute respiratory syndrome that was initially found in 2003. So this was initially an epidemic that broke out in Asia in 2002, 2003. Thought to be due to a jump from, animals to humans, specifically bats to civet cats, then to humans. And this initial epidemic was fairly self-limiting. After about 2004, there were no further cases, but it did cause a severe respiratory illness that was contagious. And then about 10 years later, there was another outbreak, another coronavirus family outbreak called, identified in Saudi Arabia. So identified as the MERS, the Middle Eastern respiratory syndrome, which caused more severe respiratory failure, fever, and there were some neurological symptoms. Fast forward to the novel coronavirus here, where we can basically see that it's like an enveloped protein. It has a capsule, and then you see that it has these spike proteins, which gives it its name, the corona, the crown, and this is what basically facilitates the entry into cells. So the initial syndrome, that was identified as a respiratory illness, a severe respiratory illness, where these patients had this heightened immune reaction, this so-called cytokine storm, where it basically then started attacking the lungs, leading to severe hypoxemia and then ARDS, as well as then other multi-organ failure, namely a lot of renal failure. These patients were on continuous dialysis, and very quickly we realized that it was not just respiratory or kidneys, but these patients were having manifestations affecting the blood vessels, affecting the heart, affecting the entire body. These patients were rapidly going to multi-organ failure. These are kind of some of the first images in terms of the severe pneumonia that was being diagnosed, where they had these patchy consolidations, and these patients were just terribly hypoxic. So what was our role as neurointensivists? So when the surge first came out, we even, although we're neurologists, as neurocritical care, we are intensivists. So we normally, our unit normally keeps, severe neurological emergencies. But what we realized was that in addition to our regular severe neurological emergencies, we were also seeing patients that had stroke, but also COVID. And sometimes we were saying, or seizures and COVID. But we were also seeing that sometimes the neurological manifestations were just essentially the first presenting symptoms before even the respiratory symptoms. So all we know about SARS-CoV-2 and coronavirus kind of fits on top of the surface. And there's so much below the surface that we still don't know yet in terms of the mechanism, whether or not there's neuroinflammation, is there invasion, is there endothelial dysfunction, is there some type of direct viral neurotropism? There's so much we still don't know yet, and still below the surface that we still are, basically, striving to discover. So just like in our center, around the world, there were early reports of neurological symptoms emerging. And of course, because China being the epicenter, the first reports basically came out of China. So this was a letter published in early April in JAMA Neurology, and it talks about basically neurological manifestations of hospitalized patients with COVID in Wuhan. And they described a case series of basically about 200 and so patients. And of the 200 patients, they discovered that they basically were able to collate that about a third of them had some form of neurological symptoms. And these neurological symptoms were both a combination of central nervous and peripheral nervous. So central nervous, like acute encephalopathy, delirium, seizure, stroke, and then also peripheral nervous manifestations, anosmia, hypergeusia, as well as paresthesias. And what was more interesting was that of the patients who met the criteria for severe COVID, nearly half of them had some form of neurological manifestation. So clearly there was something emerging about COVID and the brain. This was a case report, one of the first case reports about neurological manifestations of COVID. This was a report from Henry Ford Hospital talking about acute hemorrhagic necrotizing encephalopathy. So this was a 50-year-old woman who worked for an airline, and she presented initially with fever, cough, whatnot, and they did diagnose her with COVID, but she also had pretty severe encephalopathy, decreased level of consciousness, fluctuating awareness. So a CAT scan was done. I don't have the picture of the CAT scan, but the CAT scan showed that she had some hypodensities within the bilateral thalamus, which was odd. And so they pursued a further neurological workup, which included an MRI of the brain. And the MRI was very interesting because it demonstrated essentially these are two flare images were bilateral hyperintensities within the bilateral thalamus, as well as the mesial temporal lobe. And when you look at the susceptibility weighted imaging, these were also hemorrhagic and rim enhancing. So there was definitely a signal emerging that there was something going on with COVID and the brain. We have seen acute hemorrhagic necrotizing encephalopathy with other viral infections like influenza, which are known to have some neuroinvasive properties. And so having a similar MRI to this really brought about some of the first suggestions that there was some connection between the central nervous system and directly to the virus. So of course, it was especially in the early days, there was a lot of debate about is this association or causation? Are these patients just happen to have these symptoms, or they just happen to be associated with it, or is there a direct effect of the virus? And then more reports started to come out. Something simple symptoms like headache, ataxia, and more ill patients, they had seizures and status and severe encephalopathy, as well as a collection of strokes. And there was in the early this pandemic was really unprecedented because this was essentially something that no one knew anything about, and so the rush to publish was pretty fast and pretty intense. And yes, there was quite a lot of retractions in the early days, and of course there's lots of data that we're gathering from observational studies, bedside reports, case reports, and whatnot. But so there's a lot of noise, but I think out of that noise, you can separate a signal. And so, initially there was a lot of criticism about COVID and neurology, basically saying that, well, perhaps these neurological symptoms are only a secondary manifestation of how we're treating these patients, that they have sedation that's prolonged, they're critically ill, they're uremic, they're encephalopathic, they have multi-organ failure, they're hypoxic. So perhaps these neurological symptoms are just the end result of all of the organ failing and the sedation that we're using. However, they started to have other signal emerging, signals like patients who were presenting, who had no risk factors for stroke at all, young patients presenting with stroke, and then also finding that they had COVID, way before the typical symptoms. And so there seemed to be a signal emerging that there was a direct viral effect, and also that there may be some biomarkers, especially in severe COVID disease, that might help you identify persons at risk for neurological injury. This is a study that was published in the Journal of Neurocritical Care. Jennifer Frontera and Sharada Manali and Sherry Chow, they are some of very senior female neurointensivists working on the front lines in New York, and they got together as a global consortium to basically try to characterize all of these neurological reports that were emerging. And so this was a study that kind of reached out to represent at least 71 different adult sites, 34 pediatric sites, representing at least 17 countries. And its aim was to basically gather essentially information about neurological injury and see if we can find a rational way of emerging of biological plausibility as well as treatment options. The first thing we have to think about, we have to go back to, is what evidence do we have about how viruses affect the central nervous system? And so we already knew through animal models and autopsy studies from previous viral infections, especially RNA virus, that there were some neurotropic RNA viruses that result in both acute infections of the CNS and also kind of post-infectious sequelae. These viral infections, of course, your own innate immune system, and to a point, the viruses will try to, essentially replicate within the neurons, the microglia, and the astrocytes, and your own body innately will have a mechanism to remove these viruses. However, there will be a point in time in certain viral infections where essentially your innate immunity gets triggered, and the resultant cytokine response actually ends up facilitating the viruses further entry into the central nervous system. And then we already knew that there were quite a few respiratory viruses with neuroinvasive and neurotropic potential, including the influenza viruses, the human RSV viruses, and of course our family friend, the coronaviruses. And we knew that the coronaviruses had neurotropic potential because they had initial mice models where they basically infected mice with different forms of human coronaviruses, including the one that caused the initial SARS coronavirus outbreak back in 2002. And they found that those viruses were able to had an ability in the mice to infect the olfactory bulb within about 3 days, and within about 7 days had already spread into the frontal lobes after they sacrificed the mice and they did PCR. And there were also, we also had, scattered reports of febrile seizures and convulsion and encephalomyelitis in patients who had coronaviruses, as well as some autopsy studies in looking at coronavirus post-mortem. So the question, and then we already knew once the SARS-CoV-2 was found that and sequenced, that there was an incredible homology between the SARS-CoV-1 and SARS-CoV-2, and in the fact that both use the cell surface receptor of the ACE2R, which is the angiotensin converting enzyme receptor, for entry into the cell. So the SARS-CoV-2, basically these ACE2 receptors are found throughout the body, specifically, especially the lung epithelium, the gut epithelium, also in the vasculature, and essentially the spike proteins essentially facilitate the viral entry by binding to the ACE2 receptors, and it enters into the different organs, and essentially it triggers a cytokine release, and then the cytokine storm triggers a whole different a sequence of events, which a lot of it involves essentially fibrin plugging, vascular thrombosis, and release, whatnot, and then we have the different manifestations. But what about the brain? So we actually found out that neurons and glial cells do express the same ACE2 receptor. And the ACE2 receptor is the functional receptor for the SARS-CoV-2 and other human organs, including the brain. And the ACE2 receptors in the brain is found throughout the cortex, the motor cortex, posterior cingulate gyrus, within the ventricles, within the substantia nigra, and interestingly enough, also in the olfactory bulb. And so also into the olfactory bulb. And so, we have one mechanism of how the virus, the SARS-CoV-2 virus, actually has some neurotropic effect and can enter the central nervous system. So this was, now we're in July. So eventually we do have some autopsy data, some postmortem data. And the postmortem data, this, I think, this picture comes from a series in Cornell. But basically, these were patients who had severe SARS-CoV-2 infection, as well as signs of encephalopathy and sometimes even focal neurological deficits. And after they died in the autopsy, they were autopsied. They essentially sectioned the brain, and they found they applied RT-PCR assays, and they actually found the viral particles, especially within the frontal lobe, as well as in the endothelial cells and the vasculature. And these neural cell bodies this is a cytoplasmic vacuole with the viral particles within them. Interestingly enough, they did not find in this particular series, although only 10 patients, they did not find any of the virus within the CSF itself. And there's a couple debates about it. It's like, why would it be in the brain but not in the CSF? One possibility is that these cells are within the CSF, the viral particles are intraneuronal or intracellular, so they're just not being detected. Other theories are we just don't have the right test for it yet. As we know, the CSF testing for SARS-CoV-2 is not commercially available. So how does it get into the brain? So we think possibly two ways of entry. One is essentially a hematogenous route, and one is essentially a retrograde entry through the neuron. So in the retrograde route, viruses can essentially undergo retrograde axonal transport to reach the cell bodies within the peripheral system or the central nervous system. And for SARS-CoV-2, the hypothesis is that it enters through the ACE receptors in the respiratory epithelium, crosses through the cribriform plate, basically accesses the olfactory bulb, and then almost uses the olfactory bulb as a highway to get into the frontal lobes. And which is why there were some initial reports of symptoms of anosmia and dysgeusia. The other way that viruses may gain hematogenously is that once it basically enters through it also has ACE2 receptors on the vasculature. It enters through the endothelium and basically crosses the cytokine response, basically helps to break down the blood-brain barrier, and they basically enter hematogenously as well through the vasculature. So in terms of how SARS-CoV-2 affects the central nervous system, we think that there are some mechanisms of neuroinvasions that are direct, where, for example, through the neuronal pathway causing anosmia through the olfactory bulb. And there's also like direct neuroinvasion by binding of the ACE2 receptors within the vasculature that affect the blood-brain barrier. And there's also some indirect effects on the central nervous system, basically the sequelae of acute illness. These patients are severely hypoxic. They may be hypoxic ischemic encephalopathy. Hypoxic ischemic encephalopathy. These patients also have the damage to their vasculature. There's also like a precipitation of a coagulopathy, of hypercoagulability, which we'll talk about a little bit later. And they are at risk for developing both ischemic strokes and hemorrhagic strokes. And there's also some mechanism of basically direct cortical irritation or glial irritation and causing essentially seizures and status epilepticus. The end effect so far, what we have is essentially we have patients that die, we have patients that recover, and we have patients that may have long-term complications that we still don't know about. I call the cranial nerve, we kind of joke about it, we call the first cranial nerve the forgotten cranial nerve, because if you think about it, whenever we document cranial nerves, it always starts with, cranial nerve 2, essentially starts with sight, and extraocular movements, but no one walks around with a coffee bean in their pocket. And that was pre-pandemic. Post-pandemic, there were a lot of reports actually that came out. This is actually a report in BMJ from a neurologist who talked about how they developed anosmia, nearly a week before they actually developed the fever, the cough, and other respiratory symptoms. And the anosmia was very sudden onset. And there was other ones about anosmia and loss of taste. And then, there was there was such a collection of persons reporting these symptoms, very sudden onset, that actually it became part of like the screening criteria. And then, this was in the Lancet, published about smell and taste dysfunction. This was like from a single center experience in Italy, also on the front lines. And they found that within these patients who they, talk about the objective evaluation of anosmia and ageusia, that at least 73% of these patients self-reported either one of them. And nearly 20% of them had loss of taste and smell as actually their first clinical sign. And in terms of the days, it seemed like they peaked within the first 2 or 3 days of the infection. And then toward the end, it took them sometimes even as long as a month in order to recover their taste and smell. So what about the CNS? What about the central nervous? So that's the peripheral nervous system. But what about the central nervous system? And we started to have more of a collection of symptoms, and this is as as the weeks go by. And in one systematic review of neurological involvement of COVID-19, we found that nearly half of the CNS manifestations that were found were cerebrovascular. And then about a third were neuromuscular, and another third were what's called essentially CNS infection or inflammation, which in this systematic review, they really meant seizures, encephalopathy, and delirium. So in terms of the vasculature, we'll talk about, this was one of the first articles that emerged in the New England Journal of Medicine as a correspondence. And essentially, there's a single center report of a hospital. This is a hospital in New York, where they basically found a collection of young patients, and by young, they meant under 50, which had large vessel strokes as a presenting feature of COVID. So these patients had seemingly none of the typical medical comorbidities that would precede them to have large vessel ischemic strokes, and they came in with sudden onset ischemic strokes. And then this was a report published in Stroke, where it looks at a center in New York University, where they basically track the number of COVID patients and the number of stroke patients. And initially, they tracked it by days and also by weeks. Initially, that they, this was their number of COVID patients, this is hospital admissions, and this is deaths. And they basically, you can see there was a progressive rise and a surge. And as the weeks went on, they started to identify more and more stroke patients. So initially, the presentation of patients with stroke may have been underestimated, especially in the early wave of the pandemic, because, like I said, there was so much uncertainty that there was a combination of both. Even us in our unit, we found that there was a steep drop off in the amount of stroke patients in the first few weeks. And we realized there was a combination of persons basically not presenting to hospital and possibly dying at home, or presenting in extremis because they basically were afraid to come to the hospital, and a combination of patients who were admitted with COVID or suspected COVID who had neurological symptoms but were not investigated the same way that they would have normally investigated pre-pandemic, due to a lot of fear of examining these patients and obtaining tests. So this slide is going to talk about our own research here at the Cleveland Clinic. So this is a paper talking about essentially hypercoagulability as a mechanism of ischemic stroke in COVID-19 disease. So this is from our center. This is actually pending publication later this month in the Neurohospitalist. But this was really interesting because we had, we work in several hospitals here at the Cleveland Clinic for the Neuro ICU, and we have a hospital that's was in a hotbed of coronavirus, a little bit to the south of us, maybe about 30 minutes away. And this basically, this series, we had 3 patients. One of them was on the elderly side, but the rest of them were actually fairly young, and it kind of mimicked what New York found. These were patients who presented with neurological symptoms. 2 of them had essentially healthcare exposure. They worked in nursing homes. They were essentially like health aides in nursing homes, and they had known exposure to COVID patients. And one of them had no, it was like just a community exposure. And these neurological symptoms were all over the map, except for one thing. They were all associated with large vessel occlusion. So these patients had arterial embolism, without a source. And 2 of the 3 of the patients also had concomitant pulmonary embolisms. Had concomitant pulmonary embolisms. And so when we have these patients come in as an acute stroke alert, we do usually a CT angiography. In addition to the non-contrast CT head, we usually also do a CT angiography. This is a patient who actually has a, I'll have to just move this, give me a second, has a left M1 occlusion. And then when we do the CT angiography, we usually do the chest as well as the chest, the neck, and the head. And so oftentimes you'll get lung pathology, and 2 or 3 of patients had simultaneous arterial embolism and pulmonary embolism. Excuse me. And then we treated them actually in the same way that we would treat a typical ischemic stroke that presented within the time frame for reperfusion therapy. So actually, this particular case in the middle, who had both PE and a large vessel occlusion, essentially got both the IV thrombolysis as well as mechanical intervention with endovascular therapy, and had really great. So a TICI-3 is a perfect recanalization. This patient actually got discharged to home. The second case also had a large vessel occlusion that was able to be intervened upon. And our first case unfortunately presented outside of the window. But what was really striking about both these patients, and the 2 or 3 of the patients, because of their exposure to COVID, the known exposure to COVID, they were tested essentially, maybe the day after admission and were positive. And the other patient also had fever and hypoxia and was tested. But what was interesting upon the labs was that all of them had the markers of severe inflammatory COVID with hypercoagulability. They had elevated D-dimers, elevated fibrinogen, and 2 or 3 of the cases also had positive antiphospholipid antibodies, as well as basically either borderline elevated PTTs and other clotting factors. And then in terms of the neuroimaging, when we got the neuroimaging, following their admission, you can see the first case here had multifocal embolic infarcts here, also here in the left temporal lobe, as well as the cerebellum, involving both the supratentorial areas and as well the infratentorial areas. Our second case had a CAT scan which only had a residual ischemic stroke here essentially in the lenticular striate territory. And our third case basically had multifocal infarcts over the territory of the right MCA. So after looking at these cases and looking at their labs and how they presented, all of these patients would have met the criteria for something called, for essentially embolic stroke of unknown source. They had, clean vessels. Other than the occlusion, they didn't have AFib. They had normal EFs, normal ejection fraction and whatnot. And so, and looking based upon how they presented along with their labs, we really concluded that there was multifactorial mechanism for ischemic stroke and COVID-19 disease in terms of thromboembolism, hypercoagulability from low-grade DIC, and probably also endothelial platelet activation from sepsis and SARS. And there is a sepsis-related endothelial dysfunction, which leads to a hypercoagulable state by increasing your thrombin generation and decreasing fibrinolysis. And like I said, lab results of patients with sepsis-induced coagulopathy not only include thrombocytopenia, but also elevated D-dimer, fibrinogen levels, and prolonged PT times. So in terms of after the vasculature, what else do we have? What other central nervous system effects do we have? Things like seizures, delirium, and encephalopathy. And like I said, these are multifactorial. Some of them are, related to the illness itself, hypoxia, the, metabolic derangements like liver failure or uremia, multi-organ failure. These patients are sedated and, sometimes on ECMO. But there really was a signal emerging that these patients not only were having focal neurological deficits, but they had global dysfunction. So I want to play. This is actually just came out from CNN maybe 2 days ago. This is actually an interview with a patient from our hospital, our Cleveland clinic. She actually works here, and she unfortunately contracted coronavirus. And she basically, talks about her experience with it. It also features my attending, whose office I'm in. He talks about it, but we're just going to play. I just want you guys to just listen to the first 2 minutes of her words.
This morning, delirium is emerging as an alarming side effect of coronavirus. Aside from being a terrifying experience, it also may hurt the patient's chance for survival. Joining me now is Dr. Pravin George, neurological ICU attending physician at Cleveland Clinic, and Marilyn Schneider. She works for the Cleveland Clinic. She survived a bout with coronavirus and suffered some of these symptoms. Marilyn, great to see you this morning. I'm glad
Thank you.
You're well enough to be here with us. Why don't you tell us what you went through?
With the hallucinations is actually what saved my life. I had no symptoms truly until about 7 o'clock one night. It felt like someone poured ice on me, and I held a 104.5 temp for, until the ICU was able to break it almost 6 days later. But what got me to the hospital was on April 1st, I started hearing voices, found myself writing notes all over the house, things like feed the dog, put the dog out, get my son ready for school. My son is in graduate school, was in Michigan, wasn't even with me, and the dog had passed. We'd put the dog down 7 years prior. Didn't really affect me until April 2nd in the morning. I was laying in bed and could hear somebody asking for my help. I turned on my queen size bed and an exact duplicate of myself reaching in the air saying, "Marilyn, reach for it. Why aren't you helping me, Marilyn? Marilyn, you have to help me." And it was at that point that I reached through the hallucination, grabbed from my phone, called 911. And the next thing I know, I was standing in the middle of my street, waving on the ambulance drivers.
Oh, wow. Wow. I mean, that sounds just terrifying. Now, that was at the beginning. That was at the onset for you of symptoms. But it didn't stop there, did it?
No. In fact, I don't remember calling my sister and telling her that I wasn't going to make it. I don't remember texting my son, which he said he got a bizarre message from me. It was April 2nd was my mother's birthday, and I called her from the ED, and I said, "I'm not thinking really good." And we tried to wish everybody a happy birthday very early on. And she said, "It's a little early to wish me a happy birthday." I said, "Mom, it's not a happy birthday. I think I'm going to die today." And then once they broke the fever and I was put on the vent, some would say that it was medical induced, some would say it was a hallucination, some would say it was divine. But my pressure had dropped and my breathing had stopped for a moment. And I had a conversation with my sister who passed away 50 years ago, my father, my husband who widowed me at 37, and my grandmother and godmother who happened to be nurses, all telling me to go back.
This sounds just like it's been an incredible.
So I'm going to just pause. I'm just going to pause that right there. Uh-oh. Yeah, so I'll pause that right there. I'll have the link available if anyone who would like to watch the end of it. But what those were her words. So, she basically started off not lucid, but started off unintubated. And, she ended up being intubated and she had severe disease and she recovered. But even toward the end of it, she still recalls how much that she still has some cognitive slowing and whatnot, which is, someone may have to put the, thank you. They may have some cognitive slowing and things like that, which is not an uncommon complaint that survivors of coronavirus have. So, this was one of the initial kind of systematic reviews. Approximately about 30% of patients with COVID develop neuropsychiatric symptoms. As we're getting more and more information, we're realizing that's actually really more than just 30%. Somewhere nearly 3/4 of patients have some form of neuropsychiatric symptom. It's probably a combination of both the neuroinvasion, like kind of direct effect of the virus, as well as kind of compounded by a secondary delirium due to hypoxemia and oxidative stress from the ARDS. And so, really changes, especially if you are in a high density COVID area, changes in mental status, focal neurological deficits, should prompt testing even without typical symptoms of fever and cough. And honestly, debate still exists on how much these encephalopathies should be investigated. Should you have an LP? Should you do an MRI? Should you do EEG? Risk and benefits of exposure. And really what's unknown, we already know that from, there are basically like long-term outcome studies of persons who experience sepsis and septic encephalopathy, that those patients, in a medical ICU setting, those patients, if they do, a lot of them, if they do functional imaging later on down, or volumetric studies, that they actually have they have more cerebral atrophy than age-matched controls. So, what's going to happen with these patients who survived COVID and had neuropsychiatric symptoms? We still don't know. In terms of seizures and epilepsy, so this was our study that we published, a few weeks ago, actually probably a few months ago now. But talking about acute symptomatic seizures, our group at Cleveland Clinic was one of the first reports of basically symptomatic seizures in severe COVID patients. And so we reported essentially 2 patients who had no history of epilepsy, who were treated for severe COVID. One patient had clinical focal seizures that was captured on EEG, and another patient, essentially after his sedation was weaned, he did not wake up, and so we actually did continuous EEG, and we discovered that he was in focal non-convulsive status. And so this was our first patient who, you can see he had some rhythmic discharges in the right frontal central vertex region that actually had a clinical correlation with the clonic movements of his left arm. And then this was our second patient who did have, who had on the record, he did develop non-convulsive status. So patients with, although there was a lot of hesitancy initially to do EEGs in these patients, once we realized how we can protect the persons who are coming in to do the studies, we realized that patients who had COVID-19 and severe encephalopathy, they do benefit from continuous EEG, because there's a proportion of them that will have seizures and non-convulsive status. And honestly, if you treat them, you can actually improve their mental status. The mechanism by which the seizures are precipitated in this infection is probably multifactorial. There's probably a component of a breakdown of the blood-brain barrier from the direct invasion, and because of the microvascular sludging, because of the thrombosis, because of its effect on the vasculature, there may be an increased interaction with the virus on the endothelial receptors within the glial tissue, which is how some other seizures, symptomatic seizures in acute illness occur, and leading to some local cortical irritation. And then finally, we're just going to end with the kind of COVID and the neuromuscular complications. The peripheral nerve is sometimes the most forgotten part of the neurointensivist life. But they had a collection of neuromuscular complications, and the most common one in a systematic review was Guillain-Barré syndrome. At least 73% of these patients had Guillain-Barré, and in the patient with neuromuscular complaints had Guillain-Barré. And the Guillain-Barré symptoms developed somewhere between 3 to 24 days after the onset of respiratory symptoms. And they did have, these patients in this collection had typical electrophysiological studies, which showed either motor and sensory axonal variants and other demyelinating patterns, and typical CSF findings. In these series, they were treated, and even in our center, we treated them majority with IVIG. The cases that we've treated with plasmapheresis. We treated with plasmapheresis. And the question is this GBS, is this a para-infectious phenomenon, or is this a post-infectious phenomenon? GBS, we already know, is usually post-infectious, classically, for example, after Campylobacter, but we've seen it, after respiratory illnesses like influenza and whatnot. So there's a lot of questions. Is this a cytokine release syndrome related to excessive tissue damage on the peripheral nerves from the cytokine storm, so-called? Are there production of antibodies against the ganglioside components of the peripheral nerve, leading to some form of molecular mimicry, leading to like a post-infectious phenomenon? However, there were also reports of basically the weakness starting kind of before the infectious symptoms. So is this also a para-infectious phenomenon? Still not quite known. And then finally, in terms of what are the long-term neurological effects? So of course, patients who had strokes, they will have the sequelae of their deficits. But really the patients with critical illness and acute encephalopathy, or like in our patient who in the video we played earlier, what will be the effect upon their neuropsychiatric, their neuropsychiatric needs. We don't really know in terms of the cognition, changes in neuroimaging, but we do know that follow-up really is needed for COVID survivors, especially ones who had neurological symptoms, and perhaps with even a plan for neuroimaging and further cognitive evaluation down the line. And really, there have been multiple global registries set up for follow-up with patients with neurological symptom, which are open for registration, across the world. And so with that, I'm actually going to end my presentation. I'd just like to say, first of all, this is a beach in Cleveland, which I always tell people it's not a beach. This is Lake Erie. But special thanks to Dr. Hunt Burrows and Dr. Omalo Black, who invited me today, as well as to the Neurological Institute and my mentors, Dr. Pravin George and Dr. Christopher Newey. And actually, with that, I'll take any questions.
Thank you very much, Dr. Hepburn, for that very compelling presentation on the neurologic manifestations of COVID-19. Do we have any questions for Dr. Hepburn? And yes, I am sorry about the restroom sign behind me. I'm at the university. So Dr. Hepburn, I will start off the questioning with, you mentioned that 30% of patients with COVID-19 may have neurologic manifestations like hallucinations, delirium. Is there any evidence that some of these patients may not make it to hospital and get a COVID diagnosis, or is this usually in hospitalized patients?
So that's a great question. The fact that there's also a proportion of patients who may have some neurological symptoms, some encephalopathy or headaches, or like some kind of milder symptoms, and they just never really make it to hospital because they say, you know what, I don't want to go to the hospital, especially in the early days where testing was not really well available. So this is probably most likely an underestimation. This estimation is kind of from reports from, centers essentially, or systematic reviews of retrospective and observational reports, which are all in hospitalized patients. But yeah, there are probably more milder manifestations that are just not seen. And, there are persons who, healthcare workers who basically had COVID, returned to work, who have complained about like lingering headaches or, lingering fatigue. All of those are actually neurological, kind of neuropsychiatric manifestations.
Thank you very much. And so remember, if you have questions, you can post it in the chat, or you can unmute your mic and you can ask the question. Do we have any other questions?
Did you have any pediatric cases?
No. So I'm an adult. I'm an adult neurointensivist. So I do not see any pediatric cases.
In the literature, is there anything to suggest that the children will also have this neurological effect?
So far, yeah, there are probably differences between adults and children. We probably don't have enough data yet, but the same thing, there are neurological manifestations in terms of GBS that have been kind of in that adolescent age group, and there probably have been manifestations in terms of definitely with encephalopathy, slowing and whatnot in kids. I'm not sure if there was any reports of stroke in children. That one I'm not sure about.
Okay.
Dr. Hepburn, I know one thought might be that particularly when it relates to the healthcare workers who would have developed some of the neurologic manifestations related to probably their exposures. But when they considered the other persons who might have developed the neurologic manifestations, were there any trends seen in who it was who tended to develop neurologic manifestations?
No, I don't think we can really speciate it out. There seemed to have been a signal about of younger patients and stroke, in terms of just that these strokes were kind of like popping up in patients who didn't have, they didn't have AFib, they didn't have atherosclerotic disease, and the strokes were the first manifestations of their COVID. So essentially, they might have, when they go back and they think about it, they were like, well, I was feeling a bit tired, or I did have a dry cough. So their other symptoms were pretty mild, but what brought them to medical attention was the sudden onset of focal neurological deficit. So there seems to be, a collection of younger persons that are experiencing that. But in terms of, who, is there a particular group that's more at risk? I don't think we know that. My collection of patients have been from, I had a young patient with, like a 20-year-old girl with a woman with GBS, who also had, paranoid hallucinations and whatnot, which was really interesting because typically GBS is a peripheral manifestation. So in her case, the COVID was she had essentially a parainfectious form of GBS and was severe. It was an axonal demyelinating, form of GBS. And in addition to that, she had central nervous effects because she had vivid hallucinations. Vivid hallucinations. And what was interesting was that she seemed to have some insight, because there was one night she stopped me and she said, please don't, she literally was talking avidly to, like responding to stimuli that was not me in the room. And then she paused and she looked at me and she says, please don't leave me alone here. She goes, I don't want to die alone. So there was like this, she had some insight that what she was experiencing was not real and she was alone.
This is not necessarily your field this morning, but do you know if anybody with hemoglobinopathy, like sickle cell or G6PD, might be more at risk?
That's a great question, especially because of the effect on the vasculature. I will say, first of all, I work here in Cleveland where we just don't have a lot of, patients with hemoglobinopathies, first of all. So I don't know the answer to that question. One of my colleagues is a hematologist in New York, and she didn't feel that there was any. We talked about kind of like what we were seeing, and we didn't seem to feel that there was something different that focused on persons with hemoglobinopathies.
Thank you.
You're welcome.
Do we have any other questions? Remember, you can post your questions in the chat. And so while you think about your questions, I have another question for you, sure. Dr. Hepburn. What recommendations would you give to the house staff who, in most cases, would encounter these patients before anyone else, that they can use to help them determine if patients, one, might have COVID, and two, presenting more with neurologic manifestations and not the traditional things, sure. That we're looking for?
Well, I think, there's one good thing that, in the Bahamas right now, based upon your caseload, it doesn't sound like you guys have a high amount of, and you guys can correct me if you're wrong, because I haven't practiced in the Bahamas in a while, but just looking at the numbers, you guys don't seem to be having, you guys are not really a hotspot right now as compared to, the United States. So that helps you in a way in that you don't have to suspect every single person, because right now we're at a point where literally every single person just gets tested. We just test and we isolate whoever has it and whoever doesn't have it. But in terms of things that you should look for, would be one, at the end of the day, it all goes back to the history, especially if the patient can talk, and if they do, they do mention that they had, sudden, all of a sudden food doesn't taste as right, or something, something just isn't right with my smell. There's very few things that cause acute anosmia, meaning, really the only thing that causes acute anosmia is like a tumor that suddenly expands in your olfactory groove, or essentially trauma. So persons who basically have the sudden loss of taste and smell, that should trigger something, as well as just focal neurological deficits, sudden onset in patients who are young, who don't have typical comorbidities like hypertension, diabetes, whatnot. That should also trigger something, and essentially unexplained encephalopathy or delirium and things like that that you don't really have, you don't have a great cause, yeah, you really should suspect it. I think the harder thing would be in terms of diagnosis of seizures that are not are not convulsive, because I know that we probably don't have the ability to have continuous EEG as readily available. But if you have a patient who does have severe coronavirus disease, not waking up, I mean, it's something to consider. In our patient population, they responded quite well to basically levetiracetam. They responded well to Keppra. And the other thing would be the inflammatory markers. So things like kind of like the persons who have the neurological symptoms tend to have severe COVID, and so things like the inflammatory markers, high CRP, high ferritin, high D dimer, elevated fibrinogen, kind of borderline platelet count, borderline prolonged coagulation factors. Those things probably should trigger something as well. To think about coronavirus.
Thank you. So you do think that we should be doing the coagulation factors in any of our suspicious cases? Yeah,
I do think, and it doesn't have to be, we took off antiphospholipid antibodies, but there's probably not anything specific about antiphospholipid antibodies because those things can be elevated in essentially pretty severe infections. But I think, basic PT, INR PT and PTT, your CBC, as well as kind of the basic inflammatory markers, which are, ferritin, CRP, D-dimer, and fibrinogen. If you have kind of like a trend where all of those are elevated in a patient who has some neurological symptoms and maybe also has some history of dry cough and fever, then yeah, that is very suspicious. Also, one of our database that we're looking at essentially biomarkers for patients with seizures and severe COVID, and we are looking at actually kind of the trends of those markers in addition to IL-6, which in some of our patients, actually in both of our patients in this in our collection, were elevated. So we're trying to find things that are, we just need more patients to try to really find out, what are the real biomarkers.
Thank you very much.
Yeah, you're welcome.
Do we have any additional questions for Dr. Hepburn?
Yeah, and I'll leave my email. So I'm always available by email. Please feel free if you have some questions after the talk, after you read it, after you take a look at it, please feel free to email me. And most people have my my WhatsApp, my contact. Always happy to answer any questions.
Well, thank you very, very much, Dr. Hepburn. It was really a pleasure and a treat to have you join us for CME this morning.
Oh, thank you guys for inviting me. I really, I really wish I could be home, but I probably won't be home for a little while.
Well, good luck with the rest of your program, and we look forward to having you back home.
Okay. All right. Thank you, everybody.
And thank you, everyone, for joining. Our next meeting will be on Friday, the 31st of July, and it will be a talk on obesity medicine. And so remember, the code for today's CME is COVID-19, COVID-19, and you can claim your CME on the Sunshine Learner website as per the normal process. So thank you, everyone, and have a good day.
Okay. Bye.
Bye.